Assalamu alaikum. Today's topic is very high yield bronchiectasis. Bronchiectasis pathophysiology is airway insult. It may be due to infection, it may be due to inhalation, infection, inhalation with impaired clearance, mucostasis, immunodeficiency. This is the pathophysiology like airway insult with impaired clearance. In chronic, daily production of voluminous, thick, with or without blood tinged mucus, but in acute exacerbation, it happens due to recurrent infection with mucopurulent sputum and frank hematitis. Its etiology or contributing conditions like airway obstruction, it may be due to cancer or foreign body mucostasis, it may be due to cystic fibrosis or allergic bronchopulmonary aspergillosis. In cystic fibrosis, can you tell me which gene is problematic in cystic fibrosis? CFTR gene is mutated in cystic fibrosis. Okay. Chronic or past infection like mycobacterium tuberculosis can cause bronchiectasis or toxic inhalation. So, and some immunodeficiency immunodeficiency condition like low immunoglobulin and some autoinflammatory disease like Sjogren's syndrome can cause bronchiectasis. Sjogren's syndrome, anti-Rho, anti-La antibody positive. Sjogren's syndrome, sand-like filling in the eye. Sjogren's syndrome, there is lymphadenopathy and cervical gland is enlarged. Cervical gland lymphadenitis in Sjogren's syndrome. Okay, decreased TR production in Sjogren's syndrome. So lots of things you need to remember for diagnosing bronchiectasis. It has lots of etiologies, lots of contributing conditions. So if you find those conditions, like if you find a case of cystic fibrosis, think about underlying bronchiectasis. If you find a case of Sjogren's, think about underlying bronchiectasis. If there is any other lung finding, how to evaluate? We can evaluate via high resolution CT scan. High resolution CT scan of the chest. It is needed for the diagnosis where we will find airway dilatation. And PFT show, pulmonary function tests show obstructive pattern. Pulmonary functions show obstructive pattern. That means FEV1 by FVC ratio. FEV1 by FVC ratio is below 1.7, and there may be increased residual volumes. Okay, and etiology, investigation of the etiologies like immunoglobulin level. There may be another, there may be any kind of immunoglobulin level can cause this bronchiectasis. Respiratory culture should be done. Bronchial obstruction. How to treat, address the underlying disorder, like if there is immunoglobulin deficiency, give immunoglobulin. Airway clearance and chest physiotherapy with or without with mucolytics and antibiotics to suppress bacterial overgrowth and treat exacerbation and can treat exacerbation. Now focal bronchiectasis is usually due to upstream airway obstruction, neoplastic lesion, whereas so focal bronchiectasis due to neoplastic lesion or foreign body. Diffuse is due to systemic disease like cystic fibrosis. Diffuse systemic disease, cystic fibrosis. Focal like neoplasia or foreign body. Bronchoscopic airway inspection is required to evaluate focal bronchiectasis and diffuse of direct visualization along with diagnostic and therapeutic intervention. Okay, this look at the bronchiectasis. This one is tram track calcification. Look at the airway. Look at the artery. Airway is more than the artery. This is called signet ring. So airway is more than the arteries. So say this is signet ring. This one is the tract like tram tract calcification. This one is a tract like tram tract calcification. Okay, look at here. Lack of a bronchial tapering. Airways are dilated in the perihilar. Airway dilated in the perihilar in one third of the lung. Okay, now chest imaging, HRCT, high resolution CT scan of the chest. And characteristics findings is bronchial dilatation, lack of airway trapping, and bronchial wall thickening. Bronchial dilatation, lack of air trapping, and bronchial um, wall thickening may present similarly with um, chronic to chronic bronchitis, but bronchiectasis has more prominent symptoms. Bronchiectasis has more prominent symptoms production, and exacerbation are typically bilateral. Upper lung involvement is characteristics of bronchiectasis is due to cystic fibrosis and helps to differentiate it from bronchiectasis due to other cause. Okay, now look at this question. This 55-year-old man comes to the office for cough with productive sputum, cough for 2 years, frequent symptoms flare, 1 month characteristics increase, foul smelling, purulent sputum along with malaise. A course of oral antibiotic led to resolution of the symptom. Now she has blood-streaked sputum, blood spray. There is no fever. Okay, look at here. There is no traveling history, no pets, no cigarette. Okay, look at neck is supple with a lymphadenopathy. Okay, look at here. Diffuse bronchi, wheezes, and coarse crackle. In BC, in bronchiectasis, there is coarse crackle. In ILD, interstitial lung disease, or idiopathic pulmonary fibrosis, there is fine crackles. So coarse crackles, bronchi, wheezes bilaterally in the bases. Chest X-ray reveals, look, increased bronchial marking, ring-like shadow. And if you look closely, there is this here. In here, there is tram track calcification. In here, there is tram track. Mostly, it is understandable. This is tram track calcification. So looks like bronchiectasis. So this non-smoking with chronic production of copious, this non-smoking with chronic production of the thick mucus, occasionally streaky hemoptysis, recurrent pulmonary infection. This presentation is highly suggestive of bronchiectasis. So copious thick mucus, streaky hemoptysis, recurrent pulmonary infection, and suggestive of bronchitis. There, it is a recurrent cycle. Infectious insult plus impaired bacterial clearance, bacterial overgrowth, neutrophil infiltration, inflammation, tissue damage, and structural airway changes. If you look at the chest X-ray, in chest X-ray there is here tram track sign, and it is finally diagnosed by HRCT scan of the chest. It usually shows the signet ring, I have already told you, and this is a tram track calcification. This is tram track calcification. Okay, HRCT is the things we can diagnose. Okay, bronchoscopy actually recommended for evaluated focal bronchiectasis. If there is a focal bronchiectasis, a distal bronchiectasis, and impacted secretion, if there is focal bronchiectasis, go for bronchoscopy. Okay, look at the final question. This one, 24-year worsening cough, tenacious sputum, fever, shortness of breath for a week, blood streak sputum. Okay, this patient, no, she has fever, blood pressure 130/80. Okay, respiration 20. Examination reveals crackle in the both lung and heart sound. are normal without murmur. Heart sound are normal without murmur. There is diffuse clubbing. Leukocyte 15,000. So looks like there is an infection. Infection sputum culture shows Pseudomonas aeruginosa. Which of the following is the current symptoms? So this patient, 24-year-old boy, this 24-year-old boy has respiratory problem. There is diffuse crackle. There is diffuse crackle. Abdomen is soft, non-tender without organomegaly, but there is clubbing. Infection is present. Looks like defective chloride production. Defective chloride channel. Looks like cystic fibrosis, uh, and in cystic fibrosis is one of the risk factor of these bronchiectasis. So this patient presentation recurrent episodes of fever, tenacious sputum production, hemoptysis, physical examination of the um, crackles and diffuse clubbing. It is consistent with a bronchiectasis, a disease of the bronchial thickness, and the dilatation of the recurrent cycle of the bacterial infection. Okay, in this young patient, the underlying etiology of the bronchiectasis is due to cystic fibrosis. In cystic fibrosis, there is defective chloride and sodium transport, impaired mucociliary changes. A chronic bacterial infection ensures, uh, leading to enhanced neutrophil recruitment and excessive release of elastase, which contributes to the bronchial airway damage. Pseudomonas aeruginosa is a characteristic finding in the sputum. In addition, upper airway lung involvement evidenced by upper lung field crackle and upper lobe infiltrate is seen in this patient. Characteristic bronchiectasis due to cystic fibrosis and help to differentiate it in bronchiectasis from other cause. Okay, so that's all about bronchiectasis. Hope you enjoy.